Hi everyone. Welcome to another careers talk at Mind the Bleep. Today we have Dr. Hannah Brown, who's an ST7 paediatric trainee, doing a talk on community paediatrics. So enjoy. Pop any questions in the chat and also make sure to fill in the feedback at the end and you'll get your certificate.
Thanks very much for that introduction, Frankie. I'm a bit of a disembodied voice, I think, here, but hopefully you can all hear me okay and the slides will move. So like Frankie said, I think you've had a talk before about general paediatrics. So what I thought I'd do is talk to you about community child health, which is a subspecialty paediatrics. Give you a bit of an overview of what that is, talk about the pros and cons, and how you might want to focus your application in terms of trying to get those ever important points and any questions at the end. So I am a trainee in the Northeast, although I've done most of my training kind of around Yorkshire and up here. So some stuff is region specific, but the specialty as a whole is pretty general. So paediatrics as a whole, like I say, you may be thinking about paediatrics, or it may be something that maybe you've not really considered. I might be biased, but I think it is the best specialty. I think it's one of the last true general specialties. So whatever you're interested in, you can find a niche in paediatrics. And we are, I think, the most unusual specialty in that we really do cover everything. So you can be looking after someone right from the very second they're born all the way up to adolescence, unless you decide to subspecialise in neonates, in which case you get shot of them when they're about 2. But you really do cover everything. And if there's any specialty that you're particularly thinking about in adults, then we'll have it. So you can do subspecialty paediatrics in all of the usual things like neurology, renal, gastro, but we also have our own specialist subspecialties, which you don't get anywhere else. So neonatal medicine, which is a combination of really fiddly sort of intensive care and really interesting ethical stuff. We have a quite well-trodden route into clinical genetics, which is a really interesting specialty in itself. Lots of paediatric trainees do go that route into clinical genetics. And we also have community child health and neurodisability, which have a little bit of crossover, but they're unique specialties, really. You don't find anything quite like that in adult medicine, which I think is great. So this is probably quite out of date, and I think I stole it from Mesley, possibly. So you can see paediatrics is kind of in the middle. So in these kind of like satisfaction surveys with specialties, general practice always seems to be at the top. I think unfortunately that's changing a little bit just with everything that's going on in medicine in general. But you can see that generally in paediatrics, we're fairly happy with our workload. We don't think that it's the least manageable. We probably don't think it's the most manageable either. But despite that, we're pretty high with our satisfaction as well. So you can see that sadly, acute internal medicine is right at the bottom. So I'm not saying don't do it, but I'm just saying you could do paediatrics instead. So community child health, or sometimes called community paediatrics, is a subspecialty, like I say, in a paediatrics. And it's sometimes a little bit unclear what it actually is. Even some paediatricians sometimes aren't 100%. They think that we just do child safeguarding, or it's just seeing children with disabilities. And it's actually quite a wide range of things, and I'll talk to you about the different ones. So I think it's brilliant because most of the time children aren't in hospital, which is where most of the paediatricians live. So the clue is in our specialty name. So we're based in the community. So it's a predominantly outpatient-based specialty, but we also work into schools, we work into children's centres. So we often will be doing clinics in special schools. We do school visits if we're getting sort of play assessments or assessments in nursery. So you get to see how children actually spend most of their time and their lived experiences, which is quite different to a lot of paediatrics, where you generally only see them maybe in A&E when they're poorly, or, you know, a very quick snapshot in a really busy general paediatric outpatient clinic. Paediatrics in general is very multidisciplinary, and I think we are a pretty holistic specialty in general. But I think community child health is even more so. So we involve lots and lots of different people, and we really are thinking about how the child is within their family and how we can support the family unit as a whole. There's three main areas to community child health, and I've kind of put them in these little boxes here. So a huge part of the job is that we are trying to look after the most vulnerable children in society, and I think that's so important, and it's one of the main reasons that I am passionate about this specialty. So we have quite a big role in children who are looked after, and I don't know how much experience you guys have just in terms of the different terms that you might come across, but children who are looked after is another way of saying that children who are in care, so children who are looked after by somebody other than their parents. So they might be in a foster placement or in some other form of care. We have a big role in children who have different developmental impairment or disabilities. So the really amazing thing about community child health is that we often will be referred these children, often when they're babies, and you will follow them up right up until the point where you're transitioning them to adult care, so until they're sort of 16, 17, 18. So you get to have a really pivotal role in these young people's lives. We deal with children who have complex behavioural presentations, and in some areas they have services which will be looking at things like ADHD. It depends where you work, but a lot of the time you have a role in sort of neurodevelopmental assessments in these sorts of presentations. There's a big part of children with life-limiting conditions. So we do a lot of the advanced care planning. We think about palliative care. So if you're somebody that's interested in that sort of area, then there's lots and lots of opportunities in community paediatrics. And unfortunately, another big part of the job is looking after children who are at risk of or suspected of being abused. So safeguarding is a big part of community paediatrics. It's not the only part, but we do play a pretty big role in that. In some regions, as you probably already know, safeguarding is a part of all paediatricians' roles. But in some areas, community paediatricians will do a lot of the sort of inverted commas routine safeguarding work. So if a child is referred in by social services, then in some places it's a community paediatric rota as to who assesses that child. We also have sort of unusual roles to the rest of paediatrics in that we work a lot with education and with the local authority in ways that general paediatricians often don't. So we have statutory duties. So any child that comes into the care of the local authority has to have a medical assessment. These are often kids that are really vulnerable. They've maybe not been brought to their appointments. They might have a lot of unmet health needs. So we basically do an MOT. So we do a doctor examination and we write quite detailed reports on it. And the idea is that we're trying to seize that opportunity to look after these kids that maybe haven't had that opportunity before. And along that vein, we also do adoption medical assessments. So any child that's going to be adopted, that's part of our role as well, is trying to assess them and give as full a picture as possible to their prospective adoptive parents, just so they kind of know what they might need to anticipate for the needs of this child, because it might be quite complicated in terms of a child's experiences in the past and how that might impact them on the future. And like I said, we have a big role with education as well. So we often work quite closely with nurseries, with special schools, with SEN, so special educational needs teachers in mainstream schools as well. And we provide information and guidance from the medical side of things as to how these children can be best supported in school and how they can kind of reach their potential from an educational point of view. And the other area that community child health does quite a lot of is public health and research. So if you're a public health bod, if you're thinking that might be something you're interested in, then community paediatrics is actually great for that, because like I say, our whole role is supposed to be based where kids live and how we can improve things for them. So increasingly, I think the Royal College of Paediatrics is trying to get more involved in government policy. in terms of how we can improve the health of our population in general by intervening at a childhood level. So Community Paediatrics is having an increasing role in planning services, so working with the council, potentially working at sort of a higher governmental level as well, and also doing more research. So not necessarily lab-based research in terms of, looking at genes or very complex metabolic pathways or something, although that's still really, really important, but also doing community-based research. So what can we do locally that could make an impact right here, right now in these children's lives? So all of those things I think are very interesting and exciting. This is going to make your eyes hurt because it's making my eyes hurt, but you can see the child and the family are in the middle, and these are all the various people that are involved. So we work with lots and lots of different professionals, different paediatricians, different nurses. You often have community nurses who are paediatric nurses by training, who work out into the community with these complex children. We have specialist dentists. There's a service right at the bottom that you can see called Portage. You may not have come across that if you haven't done a paediatric job, but they're amazing. They're specialist teachers that work with young people even before they go to school, so even before they hit nursery, to support parents who have children with additional needs. So we work with lots and lots of different people. So it's a really great specialty if you like communicating, if you like lots of collaborative working and thinking about the child in front of you and how they fit in the context of their wider community. So you've got all these different people that will help the child, but will also help you and support you to kind of get the best outcome for this young person. So I was asked to do a bit of a typical week. So I'll talk you through. It's not a typical week that I'm on at the minute, just because I've been on call this weekend. But for most community paediatric trainees, they're usually on the acute paediatric rota as well. There's a few places around the region where you just do community paediatrics. But for most of us, we do at least some acute on-calls as well. So I put for my Monday, I've done an initial health assessment clinic. So that's what I was talking about with the assessments of children that become looked after by the council. So if you're looked after, that is usually because you've been removed from your parents or your current carers because of concerns about their ability to care for you. So it might be because there's concerns of neglect, or sadly it might be more sinister or serious than that in terms of abuse. So you have to be seen usually within a month of being admitted into the care of the local authority. So there's often a bit of a time pressure there. So these are quite long assessments just because they're so thorough and holistic, ideally. So that can take all morning. So I've put here child in need review meetings. So we have different children at different levels of kind of surveillance by the local authority and by social services. So depending on how much support the family needs, then they might be on something called a child in need plan. So that is a family that's needing more additional support, but isn't quite meeting the threshold for a child protection plan, or indeed for the child to be removed from the care of the family. So often as a paediatrician, you might have some input into that, because if you're seeing them in clinic, you get an impression of the family and their ability to meet the child's medical needs. Or it might be if you've done an assessment from a safeguarding point of view, then you're there to give that perspective as well. Some days I'll do just a general community paediatric clinic, so that might be young people who've been referred with behavioural problems or concerns about their development. There might be an eagle-eyed GP that is wondering whether this baby might have cerebral palsy or something like that. It generates quite a lot of paperwork, so generally you spend the afternoon doing lots of letters and various referrals. I might be doing educational healthcare plans or something like that. At least once a week usually I'll do an acute on-call, so I'll usually finish my clinic about 4:30 and then I'll go to A&E and cover the wards and special care and deliveries and A&E until usually about 9 o'clock. I might go the next day and do a feeding clinic at a special school. So we have lots of children and young people who have devices like gastrostomies or jejunal feeds. Lots of young people who have unsafe swallows, so might be on a trial of NG feeds and things like that. So that will be with a dietitian, with a speech and language therapist, and potentially with specialist teachers, just trying to get a feel for how that child's doing, and using all of the expertise and input of those different people to come up with a safe plan to ensure that that kid is growing and doing as well as they can do at school. The great thing about community paediatric training is that I have the freedom to kind of do some shadowing. So if there's a particular area that I'm interested in, so say that I want to do some tertiary neurodisability clinics, then I'm able to arrange that, and I can go to a different hospital if need be, and do some clinic work there just to get that extra experience. If I'm not doing something like that, then I might be doing some teaching, so maybe teaching some medical students, or it might be that I'm getting taught. So there's pretty regular teaching usually in most paediatric departments, and there's quite a lot online as well. I'll talk a little bit about that at the end when we're talking about how to maybe get some experience for your applications. So I mentioned that community paediatricians are sometimes on the rota for safeguarding. So if there's a worry about a child, that there's a concern that they may have been subject to abuse, then a social worker will make a referral in for a safeguarding medical assessment. So if I'm on the rota for that, then I will see a child that's been referred in. So that usually involves it usually takes a couple of hours, and that's taking a history, examining the child thoroughly, making a really, really clear note of any sort of bruises, marks, and a really clear history from everyone that's involved. And then you have to come up with your opinion and your plan. So that's your medical opinion as to, for example, if it's a bruise, if this is an accidental bruise, or if this could be non-accidental or inflicted mark. So it is really important, because we are guiding what social services then do. Because if we're saying that we think this is a non-accidental mark and there's a potential this has been inflicted, then social services then have to act on that and potentially take steps to safeguard that child, which could involve potentially removing them from their family. So you have to be very clear and very careful in the way that you communicate there. If there aren't any referrals like that, then I might be doing some guideline or some audit, something sort of quality improvement-y. And then in the afternoon, I usually do my developmental clinic. So it's probably one of my favourite things. So that is usually preschool children that have been referred in with different concerns about their development. So it might be there's concerns from nursery that this child might have autism, or there's been a query about they don't seem to be walking when they should be. Could this be cerebral palsy or something like that? And that usually involves having a physiotherapist or a speech and language therapist, sometimes OT, sometimes community nurses, health visitors, portage. So lots and lots of different people, different perspectives, just to get a really sort of holistic assessment of the child. And I usually do that in our local Sure Start Centre. And it's really, really good clinic. I learn a lot, and you get to do a really great assessment of the young person, because they're just playing while you talk to the parents, and you get to do a bit of play assessment as well, which is wonderful. Epilepsy fits quite nicely with community child health, because lots of our children with complex needs have epilepsy. So I'm involved in doing the epilepsy clinics. So that's new referrals, is this epilepsy, and follow-ups where they're diagnosed and you're trying to manage their epilepsy as best you can. And again, generates quite a lot of paperwork, and I usually try and have some time set aside that if need to, then teachers or social workers or any of the allied healthcare professionals can get in touch, because often there are lots of different people involved with these children, and it's important that we all communicate really well, just so as we're all on the same page and we know what everybody's doing. So there's lots of different young people that we see. These aren't exact cases, but I just thought I'd talk a little bit about the kinds of children that I might see. So Lottie, we'll call her, but it shows the variety of things that you can do. So you can go from doing the acute paediatric stuff. So I was at her resuscitation when she was born. She needed unexpectedly a little bit more help than we thought she would. So she needed a little bit of time in the neonatal unit. And it was noted that she had lots of dysmorphic features. And when she had her neonatal hearing screening, she was also deaf. So she's got sensorineural deafness. So now she's got a really cool bone-anchored hearing aid. So she doesn't have a genetic diagnosis as such yet. So we do a lot more genetics than we ever used to, just because that's coming on in leaps and bounds. And I think that's probably going to be a huge part of the future of paediatrics in general, but community paediatrics in particular, because we are finding out more and more about children that previously maybe would never have got a diagnosis. We are now finding microdeletions or microduplications and getting more and more information about that. So the kinds of concerns that the parents might have is about long-term, what will her development be like? And she's the kind of child that we would follow up long-term and support the parents if and when any additional needs developed. It can also be very different. So we have a really excellent clinic where I work at the moment, where children who are coming into the country as refugees are referred to by the local authority, and it allows us to do a really thorough assessment. But this young man has come from elsewhere who has an unknown diagnosis but has really complicated neurodisability and significant learning disability as well. We don't know how much medical care he's had. We don't know what his prognosis is likely to be if we have no diagnosis. So it's about trying to sort of pragmatically support the family and also potentially restart the diagnostic process for this young man. We sometimes will have young people, if they've come from settings where maybe there aren't specialist schools or there wasn't the ability to attend specialist schools, where they've maybe never been in an educational setting. And there's kind of an argument as to, well, how much do we push for that? Because if the family are taking really excellent care of somebody at home and supporting them and they're doing things that they enjoy, then in some circumstances, we say that, in mainstream schools, if no one was attending, then that could potentially be a concern from a safeguarding point of view. But for this young man, no, we didn't think so. But it's all about trying to optimise his quality of life and thinking about the future. So do we need to do an emergency healthcare plan? Do we need to think about ceiling of care? So thinking holistically, but also trying to plan for the future for him. This is a typical kind of referral that we get in the child development clinic. So a young man who's gone to nursery think that he has some issues with his social communication. He likes lining cars up, like you can see there, doesn't really want to play with other children, doesn't really talk very much. What we're seeing a lot of at the minute is everyone says, oh, it's just a lockdown baby. And there are lots of lockdown babies. You might have lots of complicated social background things, so it's not unusual for us to have children who have had quite significant social services involvement. And so then you've got a bit of a diagnostic quandary, because if there's been any issues with attachment, then that can sometimes present similar to conditions like autism. So do you want to rush into a diagnosis that's lifelong, or do you want to observe for a little bit longer? So sometimes it's about balancing those sorts of things up and trying to solve the problems that are there at the time. So if there's issues with behaviour or issues with sleep, what can we do pragmatically to help the parents with that? So can they have support from their health visitor? Is it a sensory issue? Can we refer to occupational therapy for some help with that? Sleep, sometimes we can help with. So sleep might be a support from the health visitor in terms of what is the routine like at home, but also sometimes we do think about things like melatonin for these children. And then it can range all the way through to teenagers. So again, unfortunately not that uncommon, but a teenage girl that's been referred for initial health assessment because she's now looked after by the local authority. So this is a different set of skills potentially to assessing a child with lots of different dysmorphic features. So this is about being compassionate and empathetic. And you maybe have heard of HEADS. We talk about it quite a lot in paediatrics, just in terms of trying to explore the different issues that affect teenagers in a sensitive way, and trying to meet those health needs. So unfortunately, we do often have these quite complicated situations where maybe somebody's not going to school, so we then have to work with that. We might have police involved. There are specialist services that we may be in touch with there. You might have dad that suddenly comes back in the scene and says that actually mum was drinking when she was pregnant. So now you'll have social worker asking, well, could she have fetal alcohol syndrome? Which is now called fetal alcohol spectrum disorder. So you might have all of that complicating things. So I've put about sexual assault there just because there are some community paediatricians that have a specialist expertise in forensic assessment. So that is a very specialist area, but certainly I have some consultant colleagues that do those kinds of assessments as well. And the most important thing that I think we can do there is to advocate for the child, and listen to them and just try and get as good idea as we can of what their lived experience is. And if we can do that, then we can hopefully see where their needs aren't being met and get them to the right services. So these are the kind of things that are more the sort of public health and research side of community child health. So I think we're going to see more and more research that's based for us. So health inequalities are massive for the NHS in general, but I think particularly for paediatrics, it is honestly shocking how significant poverty is in terms of your health outcomes as a child. So there's so much work that can be done there. There's a growing, unfortunately, mental health need for children and young people in the UK. And I'm sure you know that, unfortunately, the child and adolescent mental health services in general are wildly underfunded and understaffed. And there's a real sort of lack of services sometimes for these young people. Neurodevelopmental disorders. So you may or may not be aware, but we are increasingly diagnosing children with autism spectrum disorder. So the latest figures are probably that there's at least 1 or 2% of the population in the UK has autism. So there's some figures that are higher than that. Generally speaking, there'll be at least one child in every class that has autism. We've also had a recent change in our guidance for resuscitation. So previously we would only advocate resuscitating neonates from 23 weeks, but the BAPM guidance changed within the last couple of years, and we are now able to offer resuscitation from 22 weeks for neonates. Nationwide, I think the survival rates for a 23-weeker is around, now I'm going to get this wrong now, but around a third to a year. For 22 weeks, we don't have enough data yet, but it would seem sensible that we are likely to see even higher numbers of children who have potentially significant disability from that, just like we have seen significant numbers of children who do have disability from 23 weeks. So that's going to impact the services that we need to provide. Obesity always gets talked about, but it is a huge problem, unfortunately. And again, there's so few services available. But if we have some good quality research, if we could actually figure out what we can offer that works, then we might be able to fund it, which would be brilliant. There's some really exciting novel treatments. I don't know if you heard about in the news, I think it's still the most expensive drugs that the NHS offers, but that's for SMA, for spinal muscular atrophy. So there's some really, really exciting treatments for particularly certain metabolic conditions and things like that are developing, which potentially will change the course of them, because a lot of these conditions can cause lifelong disability, learning disability, and needing lifelong care. So we may see a big change in some of those conditions. And like I said before, genetics is a huge and expanding field and likely to become even more significant for community paediatrics. So what I love about my job is I think children are brilliant, hilarious. I think it doesn't matter how bad the day has been, there will always have been one kid that made me laugh or was just really cute, and that just makes a difference sometimes. In general paediatrics is a really supportive and kind specialty. I have incredibly rarely found anybody that is unpleasant or difficult to work with, and it's really fun training junior colleagues, and it's so lovely when you've got somebody who maybe comes into paediatrics saying that they're terrified of children, they don't know what they're doing, they're scared that these tiny people are going to break, and then 4 or 6 months down the line they're a really slick, confident junior, which is brilliant. Paediatrics in general is a huge variety. I sort of covered that a little bit, but if you do a mixture of community and acute, you get some really nice acute, fast-paced, quick turnaround A&E stuff. You get to do some fiddly procedures, well, as much as, I guess, cannulas, lumbar punctures, stuff like that. If you find it fiddly, you may not. You may be very coordinated. And then you've got the long-term stuff. So as a community paediatrician, like I said, you could follow someone up for their entire childhood. You might look after them for their entire life if they've got a life-limiting condition. You get to really know the families, and in some ways it's kind of like the maybe it's gone now, but how the GP model used to operate. You get to know the families and be part of the community, really. There's some really challenging communication, and it's very satisfying to get that right. And that can be in all kinds of situations, from sort of communicating a diagnosis to talking about genetic counselling to potentially explaining to a family why you're doing a child protection medical and that you've got safeguarding concerns. It's a really holistic specialty where I get to work with lots of different professions. I get to get their perspective. I learn lots from them. It's really nice, not just being very, very medical. I think it's really important because I've banged on about it, but just we get to look after some of the most vulnerable children in our society. And I think it's incredibly important that we advocate for them and we try our best to ensure that they get the best care and really the best quality of life they possibly can. It's also really good opportunities for teaching, whether that's medical students or junior doctors, or if you get a super specialist interest within community paediatrics, then you might be teaching other consultants. There's lots of research opportunities. I know lots of people who are taking time out to do those kinds of things. And paediatrics in general, but community paediatrics in particular, are very supportive of less than full time. As a consultant, you can choose whether to just do community paediatrics, so that would generally be outpatient based, no out of hours, or you might do what they call a hybrid job, which is what I hope to do when I finish my training, where you do a certain percentage of acute on-calls as well, just to keep your hand in and to kind of have a change of pace as well. Well, I won't lie to you, there are also things that can be really difficult about paediatrics in general, and maybe specifically about community paediatrics. So emotionally, there are things that can be really hard. So obviously, child deaths are really difficult. And when you're involved in them, it can be very difficult and very hard. I think paediatricians in general are aware of that, and you're generally very well supported by your colleagues and your consultants about those sorts of things. Safeguarding is difficult at times because obviously we don't want to live in a society where people hurt children or neglect them, but unfortunately we do, and that is quite hard to deal with sometimes. But again, our role is to care for the children that have had this happen to them, and we can't maybe have stopped what's happened to them, but we can try and help them going forward. There's been some really high profile stuff as well about conflict between parents and carers. You may have seen a case in the news recently about wanting to turn off life support and it going to court. There are sometimes cases like that are very difficult. Even working in sort of district general hospitals, I've come across certain things like that. So sometimes communication challenges are satisfying and sometimes they are very difficult. There's a number of ethical dilemmas in terms of, all sorts, but sort of the limits of resuscitating neonates versus, potentially end-of-life care as well. So those can be very difficult. From a practical point of view, the rotas aren't great. I can't lie. Generally, as a middle grade, you do quite a lot of on-calls. And being a specialist can have its downsides in terms of if they're, under 16, they somehow become mine to sort out. And as a consultant, it's looking increasingly like it's going to be a more senior-led specialty in terms of potentially more resident consultants, which is, you have to think about these kinds of things because you're going to spend more time as a consultant than as a trainee. And what I put there is that not everyone enjoys all aspects of the training. So if you are dead set on becoming a neonatologist, then you may not enjoy the time that you spend in community and vice versa. So we do a lot of service provision in terms of we spend lots of time in A&E managing acute paediatric problems, whereas the specialty as a whole is predominantly outpatient-based and clinic-based. So just like the adult medical trainees, sometimes you have to fight to get your training opportunities. But on balance, I still think you should join us because paediatrics is great. So thinking about paediatric training and how you would get into it and how you might sort of maximise your chances. So the paediatric training has changed slightly. So we famously had a very, very long training programme. So I'm still sadly in that. So it's currently 8 years, but it's going to change to 7. So once you are fully qualified in terms of post F2, you can apply to paediatrics. So you can join ST1 if you've got some paediatric experience. So if you took some time out and did various sort of trust grade posts or F3 or whatever, then depending on your experience, you can sometimes join later on. So sometimes you can join at sort of ST2, ST3. So during that time, you do your exams. So there are 3 clinical exams. One, well, they're not going to say any of them easy, but one is famously quite hard, unfortunately. So that's the middle one. And you do a clinical as well, which is similar to the adult medics PACES. So it's an OSCE type exam. You're a registrar usually from sort of ST2 to 3, but definitely by ST4. And then you can choose whether you're going to be a general paediatrician or a subspecialty paediatrician. So if you don't want to be an ologist of any kind, like a neurologist, whatever, then most people stay as a general paediatrician, but they might do a SPIN, we call it, and that's a special interest. So I'll mention briefly the different ones that you can do. And then about a third of us will be subspecialist paediatricians. So you apply competitively to subspecialty paediatrics, whichever subspecialty it is that you're interested in. And then you do usually 2 or 3 years of your last bit of training doing that. And you come out then as a consultant in whatever subspecialty it is. So these are all the different things you can do. So there's lots of them. Like I say, some of them unique to paediatrics, like adolescent health. What else do you do that's unique? Well, you can do inherited metabolic medicine as an adult, but I think a lot of them are paediatricians. Neonatology, neurodisability. So you can do all kinds of specialist interests, and then you come out as a consultant paediatrician with a special interest in whatever it is. So you generally apply in the winter before you're due to start, you have to get an appointability score. So there's two parts to that, which is the application form and the interview. So I had a look at this year's application, so I can't guarantee it will always be like this, but at the moment we don't use the MRSA exam. I think they have in the past, don't quote me on that, but they're not at the moment. So you get a white space form, so you talk about your past achievements, your clinical experience, your motivation for paediatrics, what transferable skills you've got, and some governance. You don't have to have done a paediatric job to apply to paediatrics, that's pretty crucial to say. And then you have an interview. So at the moment it's still virtual. I don't know if and when they plan to take that back to face-to-face. But there will be four main areas. So they ask specific questions, sort of testing how you'd communicate. So that the communication one, I think they are currently using a role player in the virtual sessions to get you to communicate something like that a mistake has been made, or something that isn't necessarily heavily paediatrics based, so you don't have to have lots of paediatrics knowledge to do it. It's just a test of your communication skills. They'll ask you basically why paediatrics. They'll try and get you to reflect on something. And the clinical reasoning, again, that's not going to be, a significant paediatric knowledge required. It's going to be more broad, so you don't have to have extensive paediatric experience to answer those. In terms of things that you could do, so I don't know what level all of you guys are at, but if you are still at medical school and you're thinking that paediatrics might be for you, then you hopefully have something like a PeedSoc at your medical school. You can become a student member of the Royal College of Paediatrics and Child Health, and that's free. I know at my uni we had the Teddy Bear Hospital, where you go in and teach kids at school about different healthcare activities, and that's very nice and just a nice way of showing that you can talk to kids. There's different, often local charities that will do basic life support training for kids. If you haven't yet done your elective, then consider doing your elective somewhere where there's a children's hospital and do some paediatrics. Don't necessarily have to do it abroad. There are lots of really excellent children's hospitals in this country as well. And most importantly, talk to us. So if you are on your paediatrics placement, or if you've done it recently, if you even breathe a vague notion that you're interested in paediatrics, we'll get really excited and we will try and find you things that might be of use, so that there will always be lots of projects and audits that you can get involved with. If you're in foundation and beyond, and you're thinking paediatrics or specifically community paediatrics, then try and get a taste a week. Because even if you're not thinking about paediatrics, I think until you actually do it, you don't know what we have to offer. And I think I've converted a few people, which is grand. You can do things like NLS and paediatric intermediate life supports that will get you points on your application. Even if you don't have a paediatrics job, then the chances are that you've probably got some sort of general job like GP or A&E. So see if you can find an audit or a project to do that's got a bit of a paediatric focus, and that will look good on your application. You can do an exam if you want to. So the first one is Foundations of Practice, I want to say. But you won't get any points for it on your application. So I'd only do it if you're keen. There's lots of online teaching since COVID. The other thing you could do, I think you may have to pay, so maybe don't do that, but you can look at the British Association of Childhood Disability, and there's also the British Association of Community Child Health, so BACH and BACD. They have journals, they have lots of courses, and there's online teaching as well, so you could check out that. Some of it is free, some of it you do have to pay for. And again, talk to us. So anyone, again, who is an F2 or is around doing paediatrics and says that they're interested, we will find you lots of stuff to try and help you with your application. And that is my quick run through of of paediatrics and community child health. I hope that it's been useful, and thank you for giving up some of your evening to listen to me. If you've got any questions, I'm more than happy to answer them.
Thanks so much, Hannah. That was really, really good, really informative, and I learned quite a lot as well that I didn't already know about the specialty. So guys, just pop your questions in the chat if you've got any at all, and I'll ask them to Hannah. Maybe to give people some food for thought, I'll just ask a couple of our own questions that we ask sometimes. So I don't know if you sort of directly covered this, but why was it that you originally picked this specialty, and what do you kind of find that you personally enjoy the most about it?
Yeah, so I wasn't always going to do paediatrics. So I thought I was going to do A&E, then I thought I was going to do GP. And then it was kind of by accident that I did the broad-based training programme, which doesn't exist everywhere anymore. I think it still is going on in Scotland, maybe, and Wales. And I did paediatrics and got a taste of community paediatrics and really, really enjoyed it. And I think it showed me that paediatrics doesn't have to just be A&E, even though that is fun. You get to be almost like a GP, but just see kids. Because, I mean, adults are great, but I don't want to spend all my time dealing with them. And I think what I get out of it is just that you get to become an expert in a child and their family. It's not just one thing. You get to really know them, and you get to support them in all sorts of different ways. It's not just about starting medication. It's kind of that holistic idea that I really enjoy.
Okay, because someone has just asked, is there any particular reason you decided to go for it over other specialties? I mean, I don't know if you have anything to add on. You've kind of just answered it, but
yeah, I mean, I don't know. Oh, I can see that actually. It's Ashlyn. I don't know if you've had much experience in paediatrics, Ashlyn, but you do a lot of acute paediatrics generally as a trainee, which I do enjoy. It's brilliant. But I think in community paediatrics, you get to do the thing that you'll do as a consultant. So as a trainee, I get to have a lot more independence and ownership over the patients that I see. It's a lot more independent, I find, than actually when you're in A&E seeing patients. But I think I really like that it is so broad and it's working in the community. So it's not just children that come to A&E or just pop into clinic. You get to make a difference to their experiences just day to day in their lives. And I think that's brilliant.
Thanks, Hannah. And what about, is in your sort of application process and in your job, what's the sort of biggest challenge you would say that you've faced, like as you go through your training?
I think the most challenging stuff is often I guess the communication side of things, and sometimes maybe the emotional response to certain things. So I kind of said that safeguarding is a big part of what we do, and that can be quite difficult from the point of view of, first of all, communicating to the family that you need to assess their child because there's worries essentially that they might have hurt them. That can be quite difficult, but also when you're doing assessments later on and working with these children, knowing that they've had these sometimes really quite awful experiences at a young age, and I guess not letting that get you down too much. And that sounds really flippant, but you can't necessarily change what's happened, unfortunately, but you can try and give that child the best chance for a good future in the limited way that we can do in terms of the medical support that we can offer. But yeah, I think that's difficult, that you know that there's so much that we could do if we had the services to offer it. But I think that's not unique to community paediatrics. That's probably the whole of the NHS. There's lots of services that we could do with if we had unlimited money, which we don't.
Yeah, and that must be quite a harrowing aspect. I suppose I didn't really think about how much you guys must be involved in all the safeguarding stuff, especially in the community. So just going back to your portfolio, when was it that you started working on this, and what sort of things did you personally do? I know you gave some advice, but just, from your own experience, what did you find was a good thing to do?
So I probably didn't start as early as I should have done. So the advice that I'm going to pass on that I didn't follow, but that other people should follow, is that try and keep a CV if you can. So I was not very good at this, but any job that you do, if you guys are already F1s or F2s, make a note of it. And if you're doing audits and projects and things like that, put it in as though it's a CV that you're going to apply to a job, and it will help you remember all of the probably really good things that you've done. Because then when it comes to writing an application for a specialty, even if it isn't paediatrics, I hope it's paediatrics, then you can kind of pull all of that together. I think the kind of things that I did do in my portfolio, I was interested in the safeguarding side of things, so I asked if there was any audits going on, and I did a project looking at how we were doing the assessments. If you do any kind of paediatric project, then the Royal College does a big conference every year, and if you've got anything that you can do as a poster, it doesn't have to be a massive project, then you can usually get that in at least as a poster, or sometimes even as a presentation, and that looks very good on your application because straight away that's a national one. So I definitely advise anything you do paediatrics related, try and get it into the Royal College conference. For paediatrics in general, like I say, you don't have to have a peds job. Anything that's kind of transferable will work. So I did have a peds job, so I was able to talk about some of the stuff that I'd done there. For the community side of things, I'd already been in paediatrics for sort of 4 years at that point. So there's often lots of projects and things that you've done, but I guess it's thinking about what interests you, and see if there's anything available. So, for example, I really like child development, which is appropriate because I do a lot of it, but there's courses that you can do specifically for that. So you may have come across sort of like the Bailey score and stuff like that. They're often not that expensive, but you can go on those, and that again is good points for your application. But yeah, I think with any application, it's mostly just looking at the scoring and seeing what have I got that will fit those boxes, and if I don't have anything, what can I do quickly to try and get some points in that area. And often if you talk to people in the area that you're applying to, they'll be able to give you some tips for quick things that can maybe help you in those sort of less full boxes.
Yeah. I think for me, when I was a medical student, I sort of was a bit lost on, well, it took me a long time to realise what opportunities I could look out for during medical school that might actually benefit me. Lots of people around me were doing different things, and I didn't really understand why everyone was doing so many extracurricular activities until I sort of look at all of these applications. So I suppose I just wondered, is there any tips in particular you've got for sort of opportunities to look out early on in medical school that might, are good things to do early on rather than a bit later? Or I know you said you worked later, so I'm not sure if you'll know, but
yeah, no, I mean, I definitely wasn't one of the people that knew exactly what I was going to do and doing stuff linked to it. I don't know. I mean, I wouldn't assume if there's something you're dead set on in medical school, crack on and do the things that you think are related to it, but maybe just see what there is, because I mean, in most medical schools they'll have various different subspecialty societies. So like I say, you'll probably have like a ped soc or something like that. It's worth going along to them and just seeing what sorts of things they do. But also I'd say don't stress about it too much. I think there is time, and it's likely that you'll change your mind. And I guess if you're one of these people that knows that you want to do neurosurgery or whatever, yes, okay, you probably do need to do some publications and stuff. But it doesn't necessarily have to be at medical school. I think it's better maybe just to get a bit of an experience of the different things, because I think unless you get to try things out, you don't know if you actually might want to do them. There's loads of specialties we don't get exposure to. And depending on your medical school, you might only have like a week or a few weeks on paediatrics, maybe, you know, in third year, and then you maybe do another couple of weeks at final year, and then that's it. And that's not always enough to know that that's what you want to do. But I guess just talk to the doctors that you're around when you are on those kind of placements. And like I said, there'll always be stuff that you can get involved with. There's always thousands of audits and posters and stuff that need doing. We'll be delighted if you want to do anything like that.
Okay. Well, thank you very much, Hannah. I think that's all of the questions I wanted to ask. No one else has popped any up yet, but I've just put the link to the feedback on the chat. So just make sure you do that, guys, and you'll get a certificate. Then you can use that in your CV, in your bank, if you ever do apply for PEDS. But yeah, thank you so much, Hannah. I'm sure everyone enjoyed the talk and found it really informative.
Yeah, I hope so. I've put my email here. If anyone does have any questions or ever does want to get in touch in terms of the paediatric application, I'm more than happy to try and help with that.
I'll just write that in the chat for people as well, in case they want to ask any more questions. Okay then. Well, thanks so much, guys, for coming. And yeah, thank you, Hannah.
No, thank you very much for letting me waffle on for a bit. It's been great.
Okay, see you later.
Take care. Bye-bye.